Introduce our next speaker. So Dr. George Fisher is a medical oncologist at Stanford, has been my mentor and inspiration for why I went into taking care of patients with neuroendocrine tumors and into research. I can think back to 2006 when I got a phone call from George who said, hey, do you want to help me on a clinical trial for NETs? And since that time, he's really inspired me to stay in this field, and it's my privilege to take care of patients with NETs and really try to bring the field forward. So George will give us our first talk. Thanks.
Thanks, Pam. Was it something I said? I didn't mean to scare you guys off so soon. Well, for those of you from the East Coast and Midwest, my apologies. We'd had rain yesterday and a frigid 62 degrees. But today is going to be better California weather, so I hope that you get out to enjoy yourself a little bit. Can I have people raise their hands if they have not been to a session like this someplace in the country? Wow, so that's great. And precisely because we have a new, vibrant group, and precisely because those of us who have been to many lectures before still have memory deficits now and again, I'm going to try to give everyone sort of a perspective of NETs in a broader context. Because much of what we'll talk about today might not apply to you as an individual. And I want your ears to perk up when you say, well, that is me, and then you can start listening to what we're talking about. Because NETs is a very diverse group of diseases, sometimes treated completely differently from one another. And I'm going to try to give you some context here. Let's see. So I always like to start with some things I will not discuss because oftentimes in the past we've had one or two or three people who have diseases that are actually not the topic of today's session. And I'm happy to talk with those people after the fact. But these are regarded as sort of misnomers in the medical nomenclature. In fact, Pam and I are trying to get them out of the medical literature. There's something called small cell neuroendocrine, large cell neuroendocrine of the lung. That has nothing to do with what we're going to talk about today. There's something called adenocarcinoma with neuroendocrine features. Again, that's not a neuroendocrine tumor. Something called garblet cell carcinoid, which is completely confusing, even confuses community oncologists a lot. And some of those people get the wrong kinds of tests because of this term carcinoid. That's not a carcinoid. That's an adenocarcinoma that resembles a carcinoid, but only in name only. Then there's a rare type of skin cancer called Merkel cell that some people put in the neuroendocrine category. That's not what we're going to talk about today. And if you have a poorly differentiated neuroendocrine tumor, that's something of great research interest to Pam and myself, and that is within our field. I'd encourage you to just meet us at the break, because that actually takes completely different treatments and actually completely different tests from what we're going to talk about today. So these are sort of the exceptions. And I apologize if any of you have this. We can talk about it at the break, but most of what we're talking about today will not apply to you. So carcinoid, where did that term come from? So 1907, a pathologist in Germany, looking through the microscope at different types of tumors, recognized that not all tumors were the adenocarcinomas of the colon, which is the most common cancer of the intestinal tract. In fact, he recognized some that had a very different morphology. The cells looked different on the microscope. And then when he asked his clinical colleagues how those patients were behaving, he found that those grew very slowly compared with other adenocarcinomas. And so he coined the term carcinoid. And, those of you who might think you're 1 in a million, you're not quite. You may be 1 in 200,000 or 1 in 100,000. Turns out that in terms of incidence, which is the number of new cases per year per 100,000 people in a population, the incidence of the various subtypes is actually quite low, totaling about 5 per 100,000. So that's a rare tumor. And in fact, I was telling Ron last night, when we were trying to get pharmaceutical companies to pay attention to neuroendocrine tumors 20 years ago, they said, well, why should we pay any attention to neuroendocrine tumors? They're too rare. There's no market value there. But in fact, if you don't look at it as incidence, if you look at it as prevalence, prevalence means the number of patients alive with that disease at any given point in time. It's actually more neuroendocrine patients, this is an old slide from 2008, more neuroendocrine patients than stomach, pancreas, and hepatobiliary combined. So those are cancers where there are lots of clinical trials. Those are cancers where there's lots of research. And why are we neglecting this large group of patients Are we biased against them just because they live longer? I don't think so. And when the pharmaceutical companies got wind of this and actually found out that drugs could get approved for this group and they could make a dime off it, all of a sudden now pharmaceutical companies are interested. And hence the support for meetings such as this from companies. Now, another curious thing is that it's increasing in incidence. So even though I said it was a very low incidence, the red bar here is the number of cases per 100,000 over time. You can see this big blip here. You would say, well, why was it from 1983 to 1985 that there was this big jump in incidence? Did somebody get exposed to a nuclear bomb? Was there asbestos in the air? Were we all eating donuts at that time? What is it in the environment that caused that? Well, nothing caused that in the environment. That's just merely an artifact of this is when octreotide was discovered. And we found out we had a treatment for these. And all of a sudden, if you have a treatment, people get a little bit more attentive to diagnosing it. So once you have a treatment, boom, we all of a sudden found more of those patients and treated them. And I think that this rise here is predominantly because we get CT scans. If you eat a bad taco and you go to the Stanford emergency room, chances are you're going to get a CT scan. And chances are your taco will wear off, you'll be just fine. But the CT scan may show a tiny spot in the pancreas, and then, aha, you're a newly diagnosed pancreatic neuroendocrine tumor that you might not have been diagnosed for 10 years, but we picked it up because of an incidental CT scan. Or if you had a colonoscopy looking for colon cancer, they might find a little nub in the colon, take it out and say, well, you've got a neuroendocrine tumor. And then the question is, what do I do with it? Well, that's the subject of the research that Pam and I are engaged with. But I think a lot of this incidence is not that the actual rates of disease are going up, it's just that we're recognizing them more often because we're doing more tests, diagnosing them earlier. So this is sort of old nomenclature, and I just say this because some people say, well, I don't have a neuroendocrine tumor, I have an apodoma. Well, you don't hear that very much anymore. Or I have a GEP net. Or I have an islet cell. That term is still used sometimes. That's basically a carcinoid tumor of the pancreas. Or I just have plain old carcinoid. Well, actually, what I'm telling you is that there are lots of different types of carcinoid. There's some that arise in the lung, and they have a separate classification system, which confuses people sometimes. And sometimes one of the classifications that was prevalent when I was in medical school was the foregut, midgut, hindgut classification. They just grouped them by where they arose embryologically. And so foregut were these, midgut were these, hindgut were these, and then you throw in the pancreatic on the side. So that's another classification system. I think these were largely done in the days where we just didn't know how to classify them, really. And so why not choose an anatomical classification? But we're getting better than that. So currently, we classify them like this. We ask, number one, what's the organ of origin? Is this from the ileum, in which case we call it an ileocarcinoid or a small intestinal carcinoid, appendix, pancreas, et cetera. We ask the question, is it secreting something or not? And if it's secreting something, what is it secreting? Does it make glucagon? Does it make insulin? If it makes insulin, we call it an insulinoma. Oma means tumor or mass. So if it makes insulin, it's a mass making insulin. It's called an insulinoma. Pancreatic polypeptide is a marker that can be produced by some of these tumors. Serotonin can be released. There are lots of different chemicals that can be released by these tumors depending on where they arise. We also ask, well, it's not enough to just release a substance. Is it actually doing anything? And as many of you know, as many people with a carcinoid might have something called a carcinoid syndrome. We have diarrhea and flushing. That's a direct result of substances that are released from the tumor and causing this syndrome. So some people with pancreatic neuroendocrine tumors can have syndromes. VIPoma, vasoactive intestinal peptide, causes profuse diarrhea, much like carcinoid can. So some people have what we call functional tumors, meaning they have a syndrome as a result of the secretion of some of these bad humors. And then probably the most important differentiation, or the most important characteristic that we look at, is whether it's differentiated or not. Differentiated is a pathology term. The pathologist looks at the tumor cells under the microscope and tries to imagine, is this tumor cell behaving more like a normal cell, or is this tumor cell behaving very far from normal? And the way that they look at that is by looking at how different the tumor cells are one from another, how many cells are actively undergoing mitosis or cell division, how much DNA or how much the nucleus takes up space in the as a function of the entire cell. And so if you wanted to sort of put a different term to this, I think of well-differentiated as well-behaved, and poorly differentiated as poorly behaved, because those tumors that are well-differentiated tend to grow much more slowly. Those tumors that are poorly differentiated tend to grow much faster. We treat poorly differentiated tumors completely differently. So one of the first and most important steps is to nail down the pathologist. And so we never have a diagnosis at Stanford and UCSF without talking to the pathologist and making sure that we have fair understanding of where this tumor lies in the spectrum of well-behaved to poorly behaved. Excuse me. So there are lots of interesting aspects of neuroendocrine tumor biology. We had a brief meeting last night, and someone confessed that they don't like the idea of being called a neuroendocrine tumor patient. Nobody likes the idea of being called a patient anyway. And so we decided to name them Ralph. So Pam's in charge of coming up with a new acronym as to how we treat Ralph. But the nomenclature gets very confusing, and neuroendocrine tumors are the way that we're trying to get the field to move to call it that, but you can call yours anything you like. These typically are called neuroendocrine because the endocrine part means they make little hormones, and these little bad humors or molecules that are released that can do other things in other parts of the body, like cause diarrhea. That's a hormonal type treatment, a hormonal type mechanism. So there's the endocrine part. The neuroendocrine means that they can be responsive to nervous stimuli or to nerves. And anyone who's had carcinoid syndrome who knows that if they get anxious, they turn beet red and they might have a burst of diarrhea or feel lightheaded and flushing, that is because these are attached to nerves, or that nerves have an impact on the release of the hormones. So that's where the term neuroendocrine comes from. Now, if you just thought of this little cartoon here as a neuroendocrine tumor cell, this is actually a cancer cell. It turns out that these cancer cells can have something called somatostatin receptors, SST receptors, and there are 5 types, always more complicated than it needs to be. Type 2 is most commonly on neuroendocrine tumors. And it just turns out that 80% of neuroendocrine tumors have type 2, and octreotide, lanreotide, 2 drugs that bind to that receptor, bind with fairly high affinity for type 2, okay? So that's why we think about using those drugs for this particular disease. We also know a little bit about neuroendocrine tumor genetics. There are genes that can be inherited from parents, either mom or dad, that might predispose towards MEN1 or MEN2 syndromes that give a higher risk of certain types of neuroendocrine tumors. Similarly, with this whole list, I won't go through it, but MEN1 is the most common of the genetic predispositions for this. We know that independent of the genes you inherit, there are genes that can go bad in the body, in the tumor, and give rise to pancreatic neuroendocrine tumors, for instance. And this is work that was actually funded by Caring for Carcinoid Foundation and with a grant to Johns Hopkins, where they did sequencing of a couple dozen pancreatic neuroendocrine tumors, and they found that a significant proportion had defective genes in these particular things I won't list for you. We also know that there are genetic changes within midgut, but not very many. There are more genetic changes in pancreatic neuroendocrine than we found in midgut. And another grant that Caring for Carcinoid Foundation funded to Harvard, the Broad Institute, which is a sequencing center at Harvard, they found that 12% had a mutation in this particular gene that we might even have some drugs to in the near future. But 12% is not a very high number, and we don't know what the other 88% have. So we're still looking. So the search continues for that disease. So now I'm going to talk about sort of the broad clinical tendencies. How do these tumors behave? Well, they tend to grow slowly, and I don't like to use that in the clinic. I mean, because what's slow to the individual who has a tumor is never slow enough, and so it's not all that good. I can go in and I'll say, good news, your tumor is slower than the guy down the hall. You know, that's not exactly what you want to hear. But compared with adenocarcinomas, that they are much more slower growing. They grow in a time frame of months to years to decades, whereas adenocarcinomas can grow in a time frame of weeks to months. And so there really is a difference between those two categories. And of course, the exception, which is a higher grade, a more aggressive, a poorly behaved subset or those that are poorly differentiated neuroendocrine tumors. As I said, these tumors can release these things in the blood, and they're kind of hormonal. They can release little amines or peptides in the blood, and these can sometimes be used as tumor markers. We can draw them in the blood and tell you exactly what your marker is. They're not as accurate as PSAs for prostate cancer, prostate-specific antigen, or you hear these other markers that are used for various diseases. They're not nearly as accurate, but they're something that we draw almost for research purposes. And if they cause symptoms, as I mentioned, their secretory syndromes are actually functional. Another very interesting characteristic about these tumors, they tend to be hypervascular. Now that means that they have more blood vessels than adenocarcinomas. We don't know why. But here's a picture. If you look at, this is a person lying down on their back, and this is a slice through them, right through the belly, right like this. And then you hold up that slice and you look at it, and what you see here is this is the right side, this is the left side, this is the backbone, this is front. This is the liver, and those dark spots are metastases, or little tumors that are growing from a colon cancer. And this is just the same person a little bit further down, and you see these dark spots there. Those are colon cancer metastases growing in the liver. These are kidneys, which are normal. Now, if you look at the liver over here, this particular person's liver has a whole bunch of little white spots. This person has only a few white spots, but they're big. These are neuroendocrine tumors. There aren't many tumors that behave like this. So these are white because they get a very rich blood supply from the artery. Here's the aorta, which is the main artery in the body, and it's bright white because of the iodine contrast that we give you for a CT scan. We make the vessels quite bright white, and here the tumors all light up like little light bulbs. But just as quickly, they then dim. So this is why you need specialized scans to look at this. If you get a standard scan, you might not see that. So these are characteristic. Not all neuroendocrine tumors look like this, but about 70–80% have this hypervascular pattern. Then we talk about staging and grading. We talk about that for all cancers. I already mentioned grade, how the cells look under the microscope, and that's what defines poorly differentiated versus well-differentiated, or poorly behaved versus well-behaved. We also define the stage, and stage for all tumors is usually 1 through 4, and it usually is defined as the extent of the disease at the time of diagnosis. And it's really an academic term. What's important for the patient and the treating physician is, where is it and can it be removed? Because if it can't be removed, then it's a job for me and Pam to come up with different treatments, or to watch, or to do specific experimental trials for. If it can be removed, then we talk to our surgeons about it. Okay? So that's really more important than stage. So don't get too hung up on staging issues. Slow growth, I mentioned that. Somatostatin receptors, I said, actually, the implications for treatment, so implications of biology and treatment. Some people have such slow growth that they don't need treatment. And I'd like to tell a story of, I remember so well because it's the first day as a faculty member here at Stanford, and I don't remember how long ago that was, it's 20-some years. But I saw this lovely guy who was scared to death with his wife. He'd just been diagnosed with an incurable cancer in Fresno, and they went in had surgery, and there was cancer cells everywhere, and they closed him up, couldn't do anything, brought him to Stanford, and he looked pretty good. And I said, well, so what's ailing you right now? He said, well, I lost a little bit of weight, but otherwise I'm fine. And so we had the pathology reviewed, and it wasn't adenocarcinoma. It was a carcinoid. It was a well-differentiated neuroendocrine tumor. So I didn't have anything to treat him with at the time. 20 years ago, we had no treatments. So I said, well, why don't you just come on back in a month or so, and we'll see how you're doing. So he did, and he was feeling fine. And so I repeated a scan at 2 months. It looked the same. I repeated a scan at 4 months. It looked the same. I repeated a scan at 6 months. It looked the same. I got a scan every year. It's been 18 years. 18, 20 years. Every radiologist report says no change. Every radiologist report looks at the prior scan from 6 months or a year earlier, and there's no significant change. But when I look 10 years earlier, there's a change. It's that slow growing. So he went for actually he's 20 years now, because he went for 18 years on no treatment, and just 2 years ago I put him on octreotide, just to slow down what was becoming a slightly increasing size of a mass. So that's how slow it can be. Now, I'll tell you, if I had given him some treatment that I had 20 years ago, I'd be taking credit for all the good health he's had. But in fact, he never needed anything. And that's one of the lessons to take from the slow growth. A lot of people don't need treatment. Somatostatin receptors, I mentioned that leads to other opportunities. We can treat the syndrome by blocking those receptors with octreotide or lanreotide. We can bind to receptors that might mediate growth or slow the growth, and that's the reason I gave this guy his treatment. They can bind to the tumor, so we can use it as an imaging agent, and I'll show you one picture of that, not a great picture. And then they can bind to the tumor, so we can link really hot radioactive isotopes to octreotide-like drugs, and then use that to deliver a nuclear bomb. So you're actually delivering a hot radioisotope directly to the tumor, and that tumor then gets that radiation. Here's a picture. I need to update this with a better picture, Pam. Please remind me to do that. This is an octreoscan. Now, nuclear medicine doctors, I always tell them they must have a vivid imagination because they can see all sorts of things in here. This is the pituitary. So this is the head up here. That's the pituitary gland. This is a person with MEN1, so they have a small pituitary tumor. You can pick that up on the octreotide scan. This is a parathyroid, so you can pick up a thyroid abnormality on it. These, I think they're trying to point out, are adrenal glands, and they saw small adrenal tumors. And then this right up here, this is a cut of the liver. Those are liver metastasis from what was a pancreatic neuroendocrine tumor. So they could see all these things with this octreotide scan. That would be very hard, and we have better scans now than the octreotide scan. So that just tells you that this drug can hone to the tumor, and we can use that for imaging. What if we, instead of attaching indium-111, which is not very hot, if we attach something that was very hot, that was very radioactive, we could do the same thing and deliver lethal doses of a radiation treatment to each one of those spots. And that's what PRRT is all about. So I mentioned this hypervascular stuff. How do these get there? Well, they get there in part because tumor cells are capable of making little factors that can stimulate blood vessels to grow. So here's a cartoon of tumor cells. And these tumor cells are making these small molecules. We'll call them angiogenic factors or growth factors for the blood vessels. Here's a normal blood vessel. So this is normal blood vessels. It's not a tumor. It's not from the tumor. It's from normal tissue that is then coerced through these growth factor receptors to grow to feed the tumor. We call that angiogenesis or blood vessel formation. Frankly, no tissue can grow without a blood supply, so our body does that naturally, but the adult body doesn't need any new blood vessels because they've got all the organs intact. Only tumors need a new blood supply, and so interfering with this process might have some therapeutic effect. And how do you interfere with it? Well, there are a bunch of different ways. If you have growth factors here, these little dots that come in and bind to a growth factor receptor very specifically, and then upon binding to that growth factor receptor, it triggers a series of events that lead for this cell to grow, to migrate, grow, multiply, and form new blood vessels. That's sort of the mechanism that they used in order to create blood supplies. If we block the growth factor, there's a drug called Avastin or bevacizumab that does that. There's another drug that blocks several of these. And this June, we hope to get the first results from clinical trials looking at bevacizumab in both PNET and carcinoid, June 2nd. We're anxious to get the results to see whether that's a beneficial treatment or not. Well, we could also block the receptor. Here we're blocking the growth factors. Here we just block the receptor to keep the growth factors from coming on. A drug called ramucirumab does that. That just got approved a few months ago for gastric cancer. That hasn't been tried in neuroendocrine tumors yet. That's on our list of things to look at. Maybe that will be a good drug for neuroendocrine tumors. The other way we can do it over here is we can block the inside, kind of at the switch system. So this goes ahead and binds. This switch wants to activate the next one, but if we can just cut the wiring of the switch with little drugs that are pills. And sunitinib is already approved for pancreatic neuroendocrine tumors because it does exactly this. Pazopanib is in clinical trials right now for carcinoid patients. We have a clinical trial that's actually started by Emily Bergsland, who's going to be talking here later this afternoon. She's the national head of this particular trial. So this is an important question. Can we block this in carcinoid tumors and get some benefit from it? I'm actually not going to go through this algorithm that Pam put together, but I'm going to correct Pam before our surgeons come in, because one of the questions that they would have seen is, well, this is an unusual tumor that we will sometimes do surgery for people who have disease that we cannot completely resect. And we'll sometimes do it because what's unresectable to one surgeon isn't to another. And many of you know Jeff Norton, and I love to tell Jeff Norton jokes because he's a big truck driver kind of guy who's got incredible hands in the operating room, and he's incredibly nice to patients, but he's kind of gruff, and he says, "Yeah, well, this guy came to me. He had an unresectable tumor, so I took it out." So some surgeons will say, no, you can't take that out. Other surgeons will say, yes, you can. And you don't want to go to so many surgeons, you finally find one that can take it out, and that person's not an expert because you could end up in more harm. So you really have to go to centers where there are experienced surgeons who do this. But that is one option sometimes. Another option is sometimes for people who have symptomatic disease, surgery is not a bad way to kind of debulk the disease and remove the symptoms. And if it's slow growing, it will just take a while to get back that way. So. Impediments to progress. I hate to leave on sort of a sour note, but we have made tremendous progress, but what's keeping us from making faster progress? Why is it that breast cancer has so many drugs approved, lung cancer has lots of new drugs approved, and why is neuroendocrine tumor, despite successes in the last 15 years, why are we lagging? Well, first of all, we don't have great laboratory models. So we're not joined by a bunch of laboratory scientists that have mice that we can grow neuroendocrine tumors in, or that we have murine models mouse models of neuroendocrine tumor genetics. We have that for breast cancer, we have that for lung cancer, we have that for colon cancer, we don't have that for neuroendocrine tumors. So the Caring for Carcinoid Foundation created a prize to the first lab. It's a little bit of a bribe, but it's working. Ron, what are we giving us, $250,000 for the $125,000, $250,000? Yeah, so $125,000 for the first lab that comes up with a nice laboratory model for carcinoid, and $125,000 for the first lab that comes up with a nice laboratory model for pancreatic neuroendocrine. So if you want to run out now and get a bunch of mice and see what you can do, that's a good way to make some money. We also didn't have a good database, and the databases for rare tumors are incomplete. And how do we learn about breast, colon, and lung cancers? We look at the pathology. We can learn which patients do well with a certain pathology. We can do additional tests looking at the genes in those samples. When you have a rare tumor, it's much more difficult to do that. So Pam actually started a neuroendocrine tissue base here and collaborated with folks at Dana-Farber, MD Anderson, Memorial Sloan Kettering, and here's Stanford in red, of course. And Caring for Carcinoid gave us the first money to do a two-year project. It wasn't nearly enough money, Ron, but it was enough to get off the ground, and we have a database, and actually one of the donors to Caring for Carcinoid Foundation has given Pam another grant to keep it going. So we have a very vibrant database that Pam can tell you about later. And then low accrual of patient trials. So you have rare diseases, it's all the more important to try to get those people to be interested and aware of the clinical trials that are available, because every person who doesn't go on a clinical trial is a missed opportunity for learning, so that the next generation of neuroendocrine tumors or the next person you see in clinic will have something better to offer them. Okay, so I'm going to just for a second, I think, go through a little bit about clinical trials. Because what works in mice, you can cure lots of mice in the laboratory, but you'll never get FDA approval for that drug until you test it in clinical trials. So it's not good enough. It's essential to cure the mice. It really helps. We don't have good mouse models, so we're kind of stuck in the neuroendocrine world of looking at patients first sometimes. But if we had better mouse models, it doesn't matter how good a treatment is. You need to take it to clinical trials. So you do a phase 1, which tests safety, and you hope that you see people in phase 1 that have good responses to treatment, but the scientific purpose of the phase 1 treatment is to test 15 to 25 patients and make sure that it's safe. You understand, does this drug go through the kidney, does it go through the liver, what are the side effects? You tabulate the side effects very carefully, you make sure that that treatment is safe. You monitor the patient's disease to see whether you're having any benefit on the disease as well. Once you establish what you believe to be the highest safe dose, or somehow an appropriate dose, then you do a phase 2 studies where you're asking, well, how well does this work in a defined set of patients? Let's say I want to test it for pancreatic neuroendocrine tumor. Maybe I'll test it on 30, 40, 50, 60 patients with pancreatic neuroendocrine tumors to see exactly what percentage of patients have benefit. And if it looks like enough have benefit that I say, well, wait a minute, this might be a winning drug, then I'll go to phase 3, where we test efficacy compared with a standard. And the standard might be drugs X, Y, and Z that have been around for a while, and then we might do X, Y, and Z plus the experimental drug. So that's a randomized clinical trial where both groups get the standard treatment, and one group gets a standard treatment plus an experimental drug. Or we might say, well, you know, this drug looks good enough by itself, maybe we'll test the standard treatment X, Y, and Z versus the experimental treatment alone, and then we'll compare the two. So that's what a randomized phase 3 trial is. There are sometimes placebo controls, but usually the placebo controls are in a situation where it's a standard treatment plus placebo versus a standard treatment plus experimental drug. Very few trials have placebo-only treatments. Those that do, we try to get them to have a crossover so that if the disease worsens on the placebo, then they get access to the drug. There are rare exceptions to that. So these require a lot more patients, and if I said that there was a relatively rare disease, we need to have multiple institutions participate to get 200, 300 patients on a trial, and Emily's doing this trial that we're moving to phase 3 right now. So I'm not going to go through eligibility criteria, but just to tell you that not everyone's eligible for a clinical trial, and frankly, we still don't have enough clinical trials. We should have a clinical trial for every patient, every stage, whether disease is growing or not, functioning or not, or prior treatment or not, but we don't. So we have to be much more selective than that. And this is the future directions that Pam can tell you a little bit about with the tissue database and what we can do with that. I just wanted to have a few take-home points. One is that there are new genes identified. I didn't go into any detail, but there are genes identified, particularly with pancreatic neuroendocrine tumors. There are new therapies that have been improved just in the past few years. Many clinical trials are in progress. It's a wonderful opportunity for people to try different treatments. And the outcomes for patients are clearly improving. So if you look back at the old literature, that's not you. The new literature is going to be better. More to do. We need better laboratory models. We're trying to invest in some. We need better understanding of the genes so we understand exactly what those genes do and ideally come up with targets for those genes so that we can target the specific genetic alterations in each tumor. And for those tumors where we don't find genetic alterations, there's still something going wrong. And that's the term we use, epigenetics. So Caring for Carcinoid Foundation is funding a group from Harvard to look at epigenetics of tumors, which are all the changes in the cell that affect genes but aren't result of gene mutations. And then, of course, we want to build on the success of the recent clinical trials, but without clinical trials, you never get a drug from point A to point B to a patient. So we need the clinical trials. So I think I'll close there, and I don't know whether there's time for a couple questions, or I'm happy to take any questions. Yeah, so 5 minutes if there are any questions, and if you're shy, we have a few
I'll just get the
that are
next
collected.
slides up while
Okay.
you're answering. Questions?
This is usually not a shy group, but, but it is early. I had to get an extra cup of coffee. I'll tell you that that sort of part of the hidden agenda here is trying to make people aware that this is, like many complex diseases, is a type of disease that needs multidisciplinary care. So although Pam and I are medical oncologists and we confer, we wouldn't make any progress without very close work with our radiologists who can do scans that are specifically tuned for this disease. The standard types of scans that you get are oftentimes not good enough. So we have scans that are specific for this type of disease because of that hypervascular nature. We work with nuclear medicine specialists so that we can do the newer octreotide scans or the dotatate gallium scans that some of you have heard of that are much more sensitive than the octreotide scans. We work with our gastroenterologists who can look down into the stomach and can do ultrasounds or biopsies of pancreatic tumors that we might not otherwise have seen or that we're still wondering exactly what it is. We work with our gastroenterologists for procedures such as that. We work with our surgeons, of course, not only to determine which patients can undergo successful removal of the entirety of their cancer, but also the more difficult cases where we know that that cannot be done, but who might benefit from surgery anyway. And there are some times with this disease that we'll say, you know, surgeon can make this person better. Can't cure them, but can make them better. And we'll go ahead and roll the dice and go that direction. Yes, sir. Yeah, good, very good. So PNET.
Can you repeat the question?
So the question is about pancreatic neuroendocrine tumors that are stable on octreotide or some similar drug, and then the question is, well, if things are stable now, when do I look into clinical trials? I'll first of all tell you that it was a clinical trial that was done in Europe and here that showed that lanreotide actually could keep pancreatic neuroendocrine tumors stable, and that just got lanreotide approved in December. Before that, we had no data. Now, we used octreotide, but we didn't really know whether it worked. Now we know that that class of drugs can work, and it was because of a clinical trial that tells us definitively that that's the right treatment. Now, if the disease is stable, then my feeling is that you don't need any additional treatment, that this is not a time for clinical trials unless you wanted to participate in a database. And so that's clinical research. It's not a therapeutic trial, but I don't know if you want to comment on your database trial.
I may do that in the next talk.
Okay.
Yeah.
So I think that that there are clinical research opportunities, even if they're not a trial. But I would say that you don't need any treatment if things are stable. Just like the gentleman I took care of for 18 years without treating it at all. Yes.
All right. I arrived late, and I apologize, but I'm just wondering to what extent the things you're talking about are applicable to bronchial carcinoids, or if you're really focusing on.
I meant to say that when I was discounting the other lung neuroendocrine tumors, large cell and small cell are lung tumors that we don't deal with. We do deal with bronchial carcinoids, and the answer is we don't know. We think that almost everything we're talking about here applies to bronchial carcinoids. Most things we do, but there aren't enough of those to study separately. So actually what we tend to do is we include them into certain carcinoid trials. Because every carcinoid trial might just have a few bronchial neuroendocrine, we look at those patients very carefully. So I think that they do have the same biology in terms of somatostatin receptors. They do respond to some of the same drugs that you'll hear more about this afternoon from Emily Bergsland. We can't give the same precise answers as to what the likelihood of response is because there just aren't enough for a good denominator. Last question, Carol.
Does it happen in metastasis that the cell that progresses mutates from the original cell, and then how do you treat that if you have two different kinds of cells going on?
Yeah.
And does that happen very often, or do you even know at this point?
So that's the new theme in pancreatic adenocarcinoma, kidney cancer, colon adenocarcinoma, that things can continue to metastasize, so the spot in the liver might look a little bit different in its genes from the spot in the colon for colon cancer or the spot in the pancreas for pancreas cancer. We haven't, the sequencing that has been done for pancreatic neuroendocrine tends to be true, meaning the spots that we see in the liver are the same as the spots in the pancreas. But that's only on 15, 20 patients, not on 3,000 patients. For carcinoid, the most recent studies are very interesting, and that is that the genes that are turned on in the one part of the small bowel are different from another tumor in the small bowel and are different from the tumor in the liver. Now, we don't know that those genes are relevant, but we can just tell you that there are changes in different sites. And if we had a drug that was specific for one of those genes, then that would be crucially important to know, are we just treating one portion of the cancer just because we had a biopsy from that area, and are we missing other opportunities? We don't have treatments for those genes, so we don't know how important those are yet. So that's an incredibly important question, and I'm just kind of glossing over it. So I'll let Pam move on, and you'll have to bear me again in a few minutes.
Yep, and lots of opportunities for questions later. So yeah, thank you, George.